Hi, I'm Jessica Glennie. I'm a nurse practitioner in the ILD Center at the Cleveland Clinic in Cleveland, Ohio. We're here at the first annual APAPP meeting here in Las Vegas, and I'm joined today with Corey Fratelli from National Jewish. Hi, Corey.
Hi, Jessica.
Hi. So today we're going to go into kind of a deep dive into ILD therapeutics. So this is a big topic, but we're going to try and tackle it as best we can. So I guess maybe we could start with maybe, Corey, what types of patients, first of all, do you see in your ILD clinic?
Yeah, that's a good question. It's funny because it's such a broad topic, right? A deep dive into the ILD therapeutics. And where do we start? And I do think it starts with the patient population. Like, who do we see? And in my mind, I always separate the two out. Like, is this a patient with fibrosis? Is this a patient with inflammatory lung disease? And of course, we know there's a third group, the ones that have fibrosis and inflammation. And until I separate those in my mind, nothing makes sense in terms of therapeutics.
Yeah, absolutely. I totally agree with that. First of all, you have to kind of figure out, what does this patient have? What is the diagnosis? That's number one to treating it. Because if you're treating somebody, with hypersensitivity pneumonitis, you might want them to get rid of their BERD or the antigen or whatever it is that's causing their HP. Somebody with IPF, that's really more of a fibrotic disease. You don't want to treat them with immunosuppression. So it really starts there with your diagnosis. What other things, do we think about when, we're thinking about treatments? And I think sometimes I also think, okay, what is the diagnosis? But also, how severe is this person's interstitial lung disease? And if we have information, what is the trajectory? I don't know. What do you think? Do you kind of go over those things as well before you're deciding on a treatment?
I agree with you. I think you have to think about, is their fibrosis progressing? Because some, fibrosis does not progress. And there are some inflammatory diseases that don't get worse. And so we do have to think about that. And then it's in terms of when do you start a medication? Or if you start a medication. It's not always, I'm seeing this ILD patient and they have fibrotic lung disease and I'm ready to start an antifibrotic medication. Or this person has autoimmune lung disease and I'm ready to start a medication. It's a much larger question than that.
Yeah, I completely agree. And, it also kind of, you have to get that patient perspective in there too. What do they want to do? What are their goals for treatment? And you get the whole gamut of, patients being very frustrated that we aren't getting to an answer quick enough, and they want to start some sort of treatment, and all the way to patients who are put the brakes on a little bit more. And so you have to kind of have that patient-centered discussion as well. So what types of medications do you often think about for your patients with interstitial lung diseases?
Yeah, so I think it goes back to those three groups. At least that's how I like to think of it and keep it straight in my mind. So 3 groups: fibrotic, inflammatory, or mixed. So luckily, the fibrotic lung diseases, things are kept simple for us, right? We have 2 medications to choose from. And I think the hardest part is what fits the patient's lifestyle best. So we'll start with that. In terms of fibrotic lung disease, we have pirfenidone and nintedanib. And it's a matter of who the patient is sitting in front of me. You have to consider the progression of their lung disease, and just in terms of fibrotic lung disease only, right? Progression of their lung disease. What other comorbidities do they have? Do they have?
Yeah, it's a big one, isn't it?
Yeah, what do you do with a patient with significant reflux?
Yeah.
What medication do you offer them?
Right.
Well, one that's not going to cause more reflux symptoms, you
Right.
know? Or someone who already is pretty thin and doesn't eat well nutritionally, what medication are you going to choose for them? One that's unlikely going to cause more diarrhea, to cause more problems. And so I think when you think about the antifibrotics, it's not so much which one do I choose, but in terms of what comorbidities am I also up against? At least that's the way I think of it. How do you think of it?
Yeah, I absolutely agree. When I get that patient who's kind of more of a frail patient, an older patient, I may be thinking, well, are one of these drugs going to be more cost than benefit for this patient? Do I want to, give them the option, but maybe do a lower dose of one of these medications? It really plays into that patient-centered discussion again. What does the patient really want as well? So yeah, that's huge. That's a huge piece of it. All of those looking at the patient as a whole rather than just the CAT scan. What does the CAT scan look like?
I think it's interesting you said a lower dose of medication.
Yeah.
We know that nintedanib has a lower dose option.
Yeah.
Do you ever play around with the pirfenidone option in terms of a lower dose? And if so, how do you choose?
Yeah. I will say I always, if I can, try and get patients on the full dosage of medication. So for OFEV, we're talking about 150 BID, and for pirfenidone, 801 milligrams TID. I do play around with doses, though I always think, some medication is better than none if they can tolerate. So I will play around with the number of pills. So pirfenidone does come in kind of a 267 milligram dosage and an 801. So if you have the patient on the 267, you can say, well, you have more nausea in the morning. Well, why don't you just take 2 in the morning and 3 the other times of the day? Or, 2 3 times a day or something like that. So yeah, definitely play around with dosages as well. And sometimes patients can tolerate it. Sometimes it's still rough.
Do your patients ever complain about the larger dose of the pirfenidone and the size of the pill? I get that quite often. Like, I'd rather take 3 pills 3 times a day than 1 pill 3 times a day.
Yeah.
Because the larger pill is huge for some patients.
Yeah, it is a little bit bigger. I get the question of how much bigger it is, which but where I get this question a lot is more so with our patients who have like scleroderma ILD, who have a lot of gastrointestinal issues. They have esophageal dysmotility and they have a lot of problems with swallowing those pills. So we come into a lot of those problems with our CTD patients too. Yeah.
Well, and that brings up this whole other realm of what other categories do we have. And so when you think about connective tissue disease related ILD, now we're suddenly bridging that mixed category. But if we take a step back to the, inflammatory ILDs, where do we even start?
Yeah. Well, I think you always have to start with your HRCT, really. I mean, that's such an important piece of, you were talking about, you can have that inflammatory, you can have kind of a mixed inflammatory and fibrotic. So your CT is so important to knowing, how much inflammation or how much fibrosis, or is there, a big mix of the two? Of course, you're putting together other things as well, including the PFTs and severity and trajectory of the disease as well. But I think that's where I usually start, taking a look at that HRCT. I don't think I can do anything without that.
So let's say the HRCT is purely inflammatory. Let's talk about antigens.
Yeah. So there's a whole group of interstitial lung diseases that are caused by various antigens that we breathe in, and one group is hypersensitivity pneumonitis, where there are a lot of molds that can cause this inflammation in lungs. So, for example, farmers who work with moldy hay can inhale this mold and cause this inflammation in the lungs. And another notable one, something hard for the bird lovers in our lives, but somebody who has a family member who's a bird might have some reaction to the antigens within the bird feathers and things like that. So we do have to do kind of also a really good detective work into what they're exposed to in their home, and then also what they're exposed to in their environment and their occupation. So coal workers with the silica exposure, various metal dusts and things of that nature, woodworking dusts and things can cause occupational lung disease, these types of interstitial lung diseases.
A couple of rare examples just to kind of remind people of just how much of a detective you have to be. I'd like to share those. Is in Colorado, we have a lot of dream catchers. that are made with bird feathers.
Wow.
And
I never thought about that.
No, I know, right? And we hang them by our bed. I mean, it's a huge Colorado thing.
Yeah.
The other thing, too, is our down jackets. Like, everyone owns a down jacket in Colorado. Like, you don't ski in anything else, right?
Yeah.
So that is kind of interesting. Well, you think, well, do you have any down jackets? No. Well, no, not your everyday jacket, but what are you skiing in? Oh, it's down.
Yeah.
It's kind of interesting. And then another thing in Colorado, in some older homes, we have swamp coolers. Instead of like air conditioning systems.
Yeah.
So that's a huge question that comes up too, is like, do you have a swamp cooler?
Yeah.
It's a couple of rare examples of where you might find an antigen that you didn't even know.
Didn't even think about. Yeah, you really have to ask those deep questions. I mean, even the bedding, they're down bedding and things like that. I had a patient who found a bird's nest in her car engine. I mean, you would never think to ask that, but just the wackiest things that you see sometimes. So let's say that we have a CAT scan, we have this patient in front of us, and maybe we see a lot of what we call ground glass opacities, and that's pretty much what we're seeing, the ground glass opacity on their scan. And let's say the patient is pretty symptomatic and their PFTs are, moderately impaired.
You're making it hard.
Yeah. What do we reach for? What's our first, treatment that we use for these patients?
Not a trick question, but I think the answer is prednisone, right?
Yeah. That medication we both love and hate, right?
I know it is a love-hate, but I also think you have to think about the severity of how they're presenting, right? What's their oxygen doing?
Yeah.
If they're not stable, if their vital signs are not stable, I'm shipping them off to the hospital for some IV Solumedrol, right?
Yeah.
But let's just say they're not that significant. Something they've been kind of dealing with or nagging at them for months. Then I think oral prednisone outpatient on the longest taper that I could ever imagine. I remember when I started in ILD, I'm like, you want me to prescribe how much?
Yeah.
How long?
Yeah.
So it's longer than you think it should be. I think I personally struggle with going over 50 milligrams a day on any one patient, outpatient. I mean, it really upsets their stomach.
Yeah.
And I don't think enough people think about that.
Yeah.
I mean, even 60 milligrams can be really tough. And so not so much, we know that prednisone is like first line therapy up front, right? Because we need to shut down that inflammatory response. But we don't always think about the consequences of that prescription.
Yeah, so it's such a double-edged sword, isn't it?
It is. I mean, on so many levels, right?
Yeah.
Because, great, we have the prednisone on board, but then you have to think about nutrition and what's their PJP prophylaxis.
Yes. Yeah, that's a big one, kind of an aside, but since we've touched on it, PJP prophylaxis is so important for these patients, whether they're on high-dose prednisone for long periods of time or, 2 immunosuppressant medications. These patients can get pneumocystis pneumonia on that much immunosuppression. So that's always, we always have to think about all the different pieces and parts that are going on. Yeah, I agree. I think I have to say I love prednisone because it's the thing that I know for those patients with inflammatory ILDs that's going to really get rid of that inflammation quickly. But the amounts of prednisone that you have to put these ILD patients on and for the amount of time, there are so many toxicities with them. Sometimes we're fighting with our rheumatology colleagues who don't usually use those amounts of prednisone as well. On what to put them on. But after, let's say now we've had our patient on some prednisone and what do we do from there? Obviously, we can't have them on this prednisone forever.
Yeah, I think this is where the art of medicine really kicks in because I wish there was a roadmap for this.
Yeah.
There's so many times I go to clinic, I'm like, man, I just wish there was an algorithm for this.
Yeah, there's no gold guidelines for this.
No, there's no standard.
Yeah, that's right.
Yeah, so typically what I like to do personally is I'll usually start at 50 milligrams and go for 7 days, right? And then I'll take them down usually, depending on how severe they are, by 10 milligrams, so like 50, 40, 30, around 20, I'll bring them back.
Yeah.
And I ask them to hold at 20 until they can get back in to see me. Because by then they should be feeling better. And I think the key is when they begin to reduce that medication, the assumption is they're getting better, but some don't. So they have a very low threshold to call me and say, look, I went from 40 to 30, my symptoms return. I can bump them back up to 40 for, a certain amount of days. Again, how many days? I have no idea.
Yeah.
You kind of have to,
Right.
you have to see, like, how are you feeling? How are you responding? But I think before you start decreasing below 20, you really need to bring them back and check even just a pulmonary function test to see, like, what is your pulmonary status? Is this kind of a new normal for you, or can we get a few extra points by maybe keeping you on 20 for a little bit longer?
Yeah.
And again, this goes back to the hardest thing in medicine is there's no roadmap for this.
Right. I think I agree with you. It's really difficult. You have to take it. It's very individualized to that patient. And I agree. The PFTs are probably, if I had one test to really assess how a patient is responding to treatment, certainly their symptoms, of course, but also those PFTs are so important. And I do kind of a similar thing. I probably start with 40 milligrams for most patients, unless it's a bit more of a severe or rapidly progressing kind of disease like antisynthetase syndrome sometimes, or patients need really, really high dose. And I go down, kind of slowly and probably have them on prednisone for quite a few months, maybe 3 months more for things like organizing pneumonia. And then I start thinking about, have they improved on the prednisone? Are they showing that, there's this inflammatory component is getting better? And then maybe I start reaching for some of my steroid-sparing agents.
Yeah, so tell me about that.
Yeah.
When does that come on, right?
Yeah. So I would say, when you said I bring patients back at 20 milligrams, yeah, absolutely. I don't want to take them below 20 milligrams until I see them back with the PFTs and see how they're feeling. And at that point, I probably would, for this patient that we're speaking of, a lot of inflammation, put them on a steroid-sparing agent. And so the two that I probably use most often are mycophenolate and azathioprine. And I think that's across the board. Those are probably the two that are used the most.
Hands down.
Hands down, yeah. So, these medications don't come without their risks as well. So there are some toxicities with those medications. We really have to monitor for myelosuppression. So we have to make sure that their blood counts are staying stable, and for azathioprine, their liver enzymes as well. And then both of them, GI side effects are probably the most common with both of those medications.
So I'm getting a little uncomfortable because, when do we kind of notice, is this just inflammatory lung disease, or should we be worried that there could be a connective tissue disease component? How do I know? How do I know that?
Yeah. No, that's a good question.
When am I crossing over into rheumatology?
Yeah,
right?
absolutely. And we basically work as rheumatologists too. So we spoke about scleroderma a little bit earlier on, and there are a number of rheumatologic diseases that cause interstitial lung disease. And getting to a diagnosis for those is really important. So scleroderma and polymyositis or dermatomyositis probably have the highest incidence within their group of having interstitial lung disease, but then rheumatoid arthritis and Sjogren's and lupus and mixed connective tissue disease as well. So we always get our autoimmune serologies for our patients, at the outset when we see them.
Like that initial visit.
It
can take weeks for them to come back. Too,
Yeah.
right? I think that's not always anticipated. We think we're going to have an answer to the serologies, and it does take weeks. So I like the idea of getting the serologies up front, get the prednisone on board.
Yeah.
By the time you're bringing them back, oftentimes the serologies are back, and then you can make decisions.
Yeah, absolutely. And I always say the hands are kind of the window into the ILD lung because, their hands can show a lot of changes that we see, the Raynaud's symptoms. You can have various rashes, dry skin, joint deformities, redness and swelling of the joints and things like that. But also dry eye, dry mouth, and muscle weakness and things like that in our patients. So we do become little rheumatoologists as well. So how does it change? Let's say you have a suspicion of somebody having an underlying rheumatologic disease. How does that change your approach with that patient?
Yeah. So let's say that at that first visit, I have no idea, right? It's just purely inflammatory lung disease that I'm seeing on the CT scan. I think the course of what we talked about is really important. So get the prednisone on board. When you bring them back, you think about, okay, let me at least start like mycophenolate or azathioprine, depending on, tolerability, comorbidity again.
Yeah.
But when those serologies start coming back and some of them look a little abnormal, that's when I tap my rheumatology colleagues. And it's more of like, I have the resources there, so let's resource the experts in that.
Yeah.
But I think at that point, it's also important to tell the patient, look, we don't know at this point if you just have this inflammatory lung disease and that's where we're going to run with it, or if this could progress into something else. And that leads us to the third category, that mixed presentation of it might be inflammatory, but it could progress to a fibrotic presentation as well, where you have the fibrosis and the ground glass. And then oftentimes, I'm partnering with rheumatology colleagues, and then the medications get really tricky because patients are on immunosuppression and antifibrotics.
Right.
And there's a constant argument, like, what do you start first?
Yeah. Yeah. And so at National Jewish, what do you start first?
Well, it's completely case dependent.
Yes.
Like you wouldn't start a patient on an antifibrotic if there's no fibrosis.
Right.
Because they're taking a medication that they don't really need at that time.
Yeah.
So then immunosuppression will come first. I think the hardest patient, the most controversial patient for our MDDs is that patient who presents and they already have fibrotic lung disease and they already have ground glass and you already have prednisone on them and they're responding to the prednisone and you're like, well, what do I do? You don't want to start two medications concurrently.
Right.
Because a lot of them have similar side effects.
Yes.
And so I do think it's like you have to look at the patient.
Yeah, absolutely.
Like definitely individualized medicine there.
I agree with you. I think, one of those hard patients is that patient with maybe rheumatoid arthritis already has an established diagnosis of rheumatoid arthritis and comes to us with a CT that looks a little bit more fibrotic or I don't know, maybe this patient, the lung is the first presentation. We find out they have rheumatoid arthritis. Well, what do we start first if they're a bit more fibrotic? I would say at the Cleveland Clinic, we generally start them on some immunosuppression because the driving force is, the rheumatoid arthritis. But it's really hard to know, especially if you have more of a UIP kind of imaging pattern. Do we lean more towards our antifibrotics? And, that's where all of this progressive pulmonary fibrosis piece has started to come in. And now we're are we lumping? Are we splitting people? I don't know. I don't know anymore.
Yeah.
So it's even for the ILD people, it's hard to know how to treat these. Again, no algorithm on how to treat.
There isn't. I think you just have to trust what you're seeing as a case. And there is no wrong way, right? There's no, if you start antifibrotic and see if they're tolerating and then start the inflammation, I do have to say most of the time we start, the steroid-sparing agent.
Yeah.
Because they're responding to the prednisone. So if they're responding to the prednisone, then you really want to stop the inflammation.
Yeah.
Because once you take the prednisone down, if there's nothing else to support that process from progressing, then it's all for naught.
Yeah.
And so I have to agree with you. It's most of the time, starting that immunosuppressive agent. And then it leads into a bunch of more choices. But then I think partner with rheumatology is really helpful. Like, do you start rituximab?
Yeah.
Why?
Yeah.
Or do you continue on mycophenolate and why?
Yeah.
And those medications take a long time to come into effect. I didn't really appreciate that at first. But it can take 3 to 6 months.
Yeah.
And telling the patient about that too.
Right. Generally patients don't know that. And I try and, I try and be the person to kind of tell them that, well, the reason we're starting the prednisone first is because that works fast. And the Cellcept, for example, is going to take 6 months, 3 to 6 months to really start working. I want to I know you have a really good relationship with your rheumatology. So who manages immunosuppression if you're sharing a patient, and does it depend?
Sometimes it depends. Usually what happens is if it's mycophenolate or azathioprine, the ILD team will manage it.
Mm-hmm.
I'd have no idea why, just to be completely honest. But once we cross over to any infusion medication, rheumatology manages it. There are some patients that our rheumatology team will manage, and that could be just because their autoimmune disease is more pronounced than the ILD. Say, for example, they have very minimal inflammatory disease or fibrotic lung disease. Rheumatology will just say, we'll monitor this and take it over, because they're going to have more flares from their autoimmune disease where they need oral prednisone, and it's nothing comparable to what we give them.
Yeah.
And if they come to see us and we're managing their immunosuppression and they're having some sort of flare in the joints, it's like, who's managing what? So rheumatology will often take it over.
Yeah. I agree. At the Cleveland Clinic, it's really what's driving, which symptoms are the worst. Is it the ILD? Is it, that's kind of the worst part of their disease, or is it more the joints and systemic symptoms? And so that kind of determines who drives what. And so, whether it be kind of the oral medications or the infusions, it'll be driven by that decision. Kind of, we'll have that conversation.
I think the important point, though, with the mixed group where patients have a fibrotic presentation and an inflammatory presentation, is that there really has to be conversation between ILD and rheumatology. And I have to say, it is much harder if you're at a small tertiary center and you have to reach across the state or even the city to the rheumatologist. But I feel like it's a nod to both professions to say, hey, let's partner with this, as hard as it may be, because I think patient outcomes are better.
Yeah. Oh, absolutely. That's hard. I don't know how some providers manage these patients if they, we're very fortunate to have such good relationships with rheumatology colleagues. So we've talked a little bit about the antifibrotics. We've talked a bit about, some of the immunosuppression, and maybe not hit all of the immunosuppressive agents, but kind of gotten into them pretty well. What other things do you usually offer your patients?
I was
what
hoping
kind
you were
of
going to ask.
Non-pharmacologic? Good.
Yeah.
Okay.
I actually was hoping you were going to ask, but I think it bridges pharma and non-pharma.
Yeah.
Oxygen.
Yeah.
Oxygen is a prescription.
Yes.
Right. I think we don't think about
it like that sometimes. Yeah.
And that's at times even harder than dealing with the prescription medications, that everyone else thinks about. Because in Colorado, at least, I really think about, one, I'm an elevation. Two, what is the patient doing? I think it's underestimated. Like, what activities do they want to do? Do they want to go for an occasional casual walk with their little tiny dog?
Yeah.
Or do they want to go for a power walk with their neighbor? One patient who's on a low flow oxygen can use, portable oxygen concentrator that's pulsed, from 0 to 3 liters. But even I tell my ILD patients, if you want to go for a power walk and you're on 2 liters, the POC is not going to be your best friend.
Yeah, absolutely.
Yeah. And so we talk about continuous flow. So pulse flow and continuous flow are big conversations we have in clinic all the time. And for me personally, I think it's activity driven. Like, I have patients mountain biking with oxygen. They ski with oxygen. It's actually pretty cute to see. Like, they don't need to give up these things they really like. I have a couple that dances, and he wears oxygen.
That's awesome. So what does he do? Does he a backpack? Because I would imagine that kind of bobs around on your hip or whatnot.
So actually, I wish I could show everyone a picture. But there's camelbacks that have water in them.
Yeah.
So what he does is he gets the small tanks of continuous flow oxygen and puts them in the camelback and then runs the line through the water hose, like where the water hose should be. And so there's no oxygen tubing in front of him. And then he has the hip harness to take the weight of the canister.
Yeah.
And then you can strap it tight to the back.
It's just
and
amazing.
He salsas.
It's It's amazing what patients come up with. So maybe not quite as much salsa and skiing in Ohio, but my patients, they got to get out there and cut their, acres of land, on their ride-on mower. I mean, you should see the different things that they come up with how to put this tank onto their ride-on mower and all this kind of stuff. Just amazing. So do you have any, I know from my perspective, sometimes, especially talking to a patient about, hey, you've outgrown this POC, this isn't going to work for you. You have to, I really need you to use continuous oxygen, so you've got to use these tanks. Do you have any tips for me on how to, or for anybody listening, it's hard. It's hard to get patients to want to drag those big tanks around, but the importance of getting that through to them, what do you tell them? What do you say?
Well, first of all, I realize it's a very sensitive conversation, right?
Yeah.
It's a life changer.
Yeah.
Like, it's completely life-changing because now you're really tethered in so many moments, whether it's going out gardening, a lot of our folks garden too, or just being able to get to the doctor.
Yeah.
It's huge. And so I just tell them that they absolutely can no longer use a POC. And I let that digest with this huge pregnant pause. And I tell them, like, I'm just going to pause here for a minute and let that sink in.
Yeah.
And usually what happens in that pause is they say, well, why can't I?
Yeah.
And the biggest driver, I think, that motivates people is that it will result in muscle fatigue. Because your muscles house so much oxygen. Yeah. And I tell my patients that your heart and your lungs will steal it, from the muscles. And the muscles is what keeps you strong and going and able to garden or able to bike or able to power walk. And I say, like, look, just try it.
Yeah. Just the try it. This doesn't have to be permanent. Let's try it.
Let's just try it.
That's sometimes easier to swallow.
Yeah. And then also sometimes what I connect it to is, I get this is a big change. Let's try pulmonary rehab in conjunction with that.
Yeah.
And we have really good options for pulmonary rehab. There's a bunch of centers locally, if patients don't want to come to our facility, that are really good at pushing patients who want to be pushed. And they enjoy going, and then they learn how to use the high flow properly. And not be afraid to turn it up when they need to. Because that's the other art of it when you get into high flow need is it safe to turn it up? When do I turn it up? Yeah. How do I monitor my oxygen saturations? And it's not always what we can deliver in clinic. And so sometimes when I have the conversation of, you can't use your POC anymore, and after I let that digest and we talk about, okay, what things do they want to do? It's a whole other education session. So sometimes I say, how about you come back in 2 weeks? Yeah. There's going to be more questions in 2 weeks than you have now.
It requires a lot of education, doesn't it? Yeah. For even patients sometimes don't know that, they can turn it up if they see on their own home pulse oximeter that things are below that 88% number that we give them, or 90%, whatever it is at your facility, that they can kind of turn it up a little bit. So you mentioned pulmonary rehab, and I love pulmonary rehab. And sometimes I also have to kind of really goad patients into going, and then they come back and say how much they love it. But that's another big piece of kind of the non-pharmacologic piece for these patients. And I think we talked about comorbidities a little bit before with like reflux and other things like that.
Who owns the reflux medication?
Yeah, right.
This is like a slippery slope as well, right?
Yeah.
I feel like it is anyway.
I usually just order it, but if it's something more significant, especially a patient with scleroderma that has a lot of GI issues, I'm getting them over to GI. I don't want to deal with it.
No, I agree.
Yeah.
I agree. It's just too much to monitor. You have to know like where your zone stops and the other one begins.
Yeah. Do you monitor patients? I mean, this is going a little outside of ILD, but a comorbidity in ILD is pulmonary hypertension. It's a big one. I mean, if patients have interstitial lung disease and pulmonary hypertension, they have really much worse outcomes. So is that something that you're regularly doing, or just if you suspect it for your patients?
So we screen for pulmonary hypertension quite regularly. And again, we have probably just as close a relationship with our pulmonary hypertension team as we do our rheumatology team. Because the patients who do have pulmonary hypertension, those medications are complex, and fluid levels, being euvolemic or, having too much fluid and knowing how to have the education around the medication that they need to be on.
Yeah.
It requires a lot of nursing support and provider support. And that's where we just draw the line, and we're like, look, we need to team up really closely for this patient. And so we don't own that at all. We'll watch and monitor for side effects, but say a patient comes in and they're like 10 pounds heavier and they're short of breath. What we do is a really thorough pulmonary assessment, and we say, okay, this cannot be a pulmonary issue. This is definitely your pulmonary hypertension. And I'm right on the phone saying, can you get this patient in today? Or do I send them to the ER? What do you want me to do? It's just not possible to manage everything.
Yeah, I agree. So, and especially since we've had a medication that can be used to treat PH-ILD, I'm definitely screening more with like NT-proBNPs, echoes, especially if I have concern for pH for a patient. And then the last thing I'll just mention is, for those patients with really advanced disease, at the Cleveland Clinic, we have a really large lung transplant center. And so I'm pretty frequently sending patients over. I might not send them over the first time we see them because we have such a close relationship that I can get them there pretty quickly. But in general, I think it's a good rule of thumb for these patients to, if they kind of meet the criteria for lung transplant, to get them set up with a transplant team, especially those IPF patients that tend to progress.
I agree. And then the kind of counterpart to that is, what if they don't qualify? Is palliative care.
Yeah, absolutely. Yeah. So we're leaning heavily on our palliative care team at that point as well to kind of, help us, kind of discuss goals of care and help with symptom management and that sort of thing.
So I'm going to put in a plug for a deep dive into palliative care therapeutics.
I like that.
I know that's a challenge.
That'll be a good
the
one.
Next APAPP podcast.
I like that. Yeah. Right. That'll be, because there are a lot of good therapeutics out there that can help patients with their dyspnea, with their appetite, with their cough. Cough is a whole nother thing that is very hard to manage. But yeah, that's a good topic to discuss at another podcast.
Exactly.
Yeah.
Well, it was great hanging out with you today. I had a lot of fun.
It was great. Thanks so much, Corey. This has been a good conversation.
Yeah. We'll catch you soon.